Okay, so we're going. Heather, I'm Italian, so I'm a very visual person. You just got to tell me. Do you see this authentication? I don't know why that's going on.
I'm not seeing it.
Here we go. Okay, so we're going to go ahead and take a break in an hour. So it's 7:34, so we'll try and break at 8:34. And as I said, I am Teresa. I'm a clinic manager at Ohio State University. I work in an outpatient rehab clinic. I have a lot of adult neuro background. I have pediatric background, more from proxy. I work with more adolescent teenagers, but the little kiddos we send to our children's hospital. Heather, do you want to introduce yourself?
Sure. So I'm Heather Corin. I'm the Director of Assistive Technology at Westminster Technologies. I've been Resna certified since 1998 or 97 actually. Worked at University of Washington, East Carolina University. Worked for a couple United Cerebral Palsies, and I'm now working for Westminster Technologies out of Cleveland, but I'm from Pittsburgh.
So we'll definitely be complimenting each other a lot. So Charlie is the contact at Resna. So if you hear us saying, email Charlie, it's because he is really the brains behind it, and he does all the operational. So he does the registration. He'll be sending out the emails. We'll try and talk with him throughout it, but he is the Resna person. So he's definitely a great resource. So moving on. So the fundamentals course is 7:30 to 9:30. If we don't need the whole time, we'll end early. If we get off track, we'll readjust where we need to. And if you need to email questions, just put Resna FC in the subject line, just because it draws our attention to it. You will get a book, which is Fundamentals in Assistive Technology, 4th edition. It is not required for the course. It's more of a good complementary resource to have. If you have not received it, it is on its way. You will get a practice exam as part of this fundamentals course. It's included as part of your registration. The practice exam is at the end of all these courses, and it's at the end because they intentionally want you to have a chance to go through and have the best chance of passing it. You have 60 minutes, so once you start it, you have 60 minutes to finish it, and it's very built similar to the exam as far as the domains. They break it up into the different domains of how much percentages on seating versus AAC versus all the different areas, and it'll give you an idea if you have a weak area that you need to focus on. But we are not writers of the exam. There needs to be a separation of duty, so we are here to guide you on the problem solving and best practice. So use this course to prepare for the exam, and then we'll try and give you some guidelines and tips along the way. At the very end, we give tips for taking it, the exam. Okay, trying to advance my slides. So it is a live webinar, as you've seen. We are recording everything so that you can view it later. It is available for 60 days post-course. We definitely want you to ask questions in chat. Definitely want you to mute yourself when you're not talking. We know that we all have lives happening, and as much as we can just try to keep it behind the scenes, the better. We want you to be able to have access to the handouts. So during class, the materials tab in the toolbar is where you can access it. And then after class, there's a course catalog link that Charlie will send to you. And the link is the same for each email. And I know there's been some confusion in the past. You use your login for however you registered. Is there a hand up? Nope. Questions? Okay. No, we just like to say materials are copyrighted for you and only you. We just ask that you don't share that with others and use it, for your right as a learner. I already mentioned we're going to take a break halfway through, so you can kind of pace yourself. After the course, you'll be emailed a link for the course eval and post-course assessment. You have to do the evaluation and the course assessment to receive a link for the exam. And we do that because we really want feedback on how the course is going. Any questions so far? Okay. And then I already said you have access to the course post. Okay. So now we're going to go into some review of this actual, I don't know, I'm not good at this since I'm having trouble with, but there's a toolbar here. So what I did was I just got off the computer and I went onto the phone. Here's where the materials link is. And then this is the chat bar. So you can raise your hand and you can type a chat. Heather and I will be helping each other navigate because it's hard to kind of watch both of them. So these are some help buttons for using the phone and the computer, and then the chat. And pointers, so the raise your hand is something that you can do with the function, and that tells us that you're doing a chat. I probably won't do as many polls and tests as maybe Heather or other instructors, but we do have that feature, so we may use it on more sessions than others. And they're saying to reduce the computer microphone, avoid use of the computer microphone for the feedback. Any questions about that? Okay. So we'd like to give a kind of overview of Resna, which, as you know, is Rehab Engineering and Assisted Technology Society of North America. We believe it's a premier or professional organization dedicated to promoting health and well-being for people with disabilities through increasing access to technology. I've always thought that Resna is my home. So I'm an occupational therapist, but through AOTA, there's not a lot of therapists that do assisted technology. So I find a lot more resources and colleagues through Resna. And so we feel that the field is advanced by Resna offers the certification. So I think of my AOTA as my licensure and my OT certification, but then my assisted technology certification comes through Resna. So I find them very parallel, and I think APTA would be similar. So Resna does continuing ed, they do professional development, they have a whole area of standards development, and they really take pride in disseminating best practices out to the clinic. You can find some good research related in with the Resna, and a really good place for advocacy. So feeling like it's a place to mentor the next generation. I definitely found my home here, and now I'm pulling some of the younger clinicians in to advance and benefit from the membership. So I've said that I'm an occupational therapist. There are other physical therapists, speech therapists. Then what I love is the rehab engineers. I met one of my best mentors friends through this Resna organization. And so I always have thought that therapists and engineers are good partners, and this really brings us to the common ground. We also have assistive technology specialists, so people that are, I find a lot of these in the school systems, and Heather, please feel free to jump in if you want to add. But computer scientists and developers, educators, manufacturers, suppliers, inventors, and forum. Someone needs to mute. Someone just joined. Can you mute? Thank you. So when you're a member of Resna, you get the journal, which online subscription. The really great thing about that is I work at the Ohio State University, but I'm embarrassed to say that OSU doesn't subscribe to the Resna journal. So I only can get the articles if I'm a member of Resna, which just shows you how that benefit alone is really valuable. You get discounts on the annual conference. There's different education offerings that you get discounts on, and you get discounts on your certification fee. So when you research, networking, professional development, member news, logos. I could probably talk about this all night. They also have specialty groups. So there's professional specialty groups that looks at more the I'll say clinical because I'm a therapist, but looking at the professional interests of the individual. So bringing all the suppliers together, bringing the educators together. So if there's professional topics that want to be discussed. But then there's also special interest groups, which is where you practice. So I, in wheeled seating and mobility, collaborate with OTs and suppliers and voc rehab and engineers. And so I'll have multiple disciplines under my special interest groups. But when I want to go and look at maybe the licensure and professional needs of the clinician, I will be with my PSG group, which is my clinicians. The annual conference it has been in, I see a question. It's been in DC the past several years. This year it's in June. The call for papers is open right now. So if you have a topic that you would love to share, go to the Resna website and you can find some really good information about that. So certification. So hopefully a lot of you are interested in the certification. That's hopefully why you're here. It's a process that's voluntary where people demonstrate the level of knowledge that's required in the profession, occupation, role, or skilled. And if you think about it, it's to prove to the stakeholders and public that we have advanced knowledge in this special area. So the hallmarks of certification is that it's voluntary, so it's not a mandated process. It's by a private organization, so it's not my OT licensure that's mandating it. It's an independent, free organization, and it provides public information on individuals that successfully completed the cert process. With our reimbursement right now, it really helps us stand apart from others that we have an advanced knowledge base in this area of practice. Medicare has adopted that anyone with a Group 3 power chair has to be evaluated by a supplier that has an ATP. My bias is that it would be nice if the clinicians had some type of separation of recognition so that, like right now, I have one insurance company that's doing second reviews on our seating evals, and the individual doing second reviews has not demonstrated any knowledge of the wheelchair seating, and they are downgrading our clinical eval. And we're saying that we are specialists, we have this certification. So our advocacy is to the public, we have proven that we have this advanced knowledge. So when you're making a decision, you should make a decision by the most invested and certified, knowledgeable stakeholder. Are we able to print these slides tomorrow? I believe so, Emily. If you cannot print them, I would email Charlie and have him email you a separate email file. So Resna maintains 2 globally recognized certificates. There's the ATP, Assistive Technology Professional, and then there's the Seating and Mobility Specialist. So the ATP is, I don't want to use the word generalized, but it spans the entire seating, wheeled mobility, computer access, AAC. Everything that we have in this course is for the preparation of the ATP. After you pass that, you then can go and do the SMS, which is Seating Mobility Specialist, and that is considered one above and beyond the ATP, and it shows you that you have advanced knowledge with seating and mobility. We did update the exam in 2017, and if you speak to somebody that took the exam before 2017, they had a different version. Our practice exam includes current exam questions and also looking at the diagnostic reporting as far as the correct and incorrect answers. So the second half of 2018, there's an online application for certification and recertification. And then we also were able to translate the ATP exam into Arabic, the financial assistance provided by MATA, Assist Technology Center. There is a question about, is there a special cert for AAC? Not yet. That's the intention, is that our hope was after we got past the seating mobility, we would then have one for the other areas. I don't have a timeline for that, but I was fortunate to be involved in the development of the SMS, and they said that took a while between the ATP and the SMS, and I'm not surprised if we don't see that AAC coming up. So the ATP cert, as I said, is premier cert for professionals that work in the area of assistive technology. I love how it says indicates a level of proficiency to assure clients receive quality care. As of current, there's 4,093 ATP certificates that are certified, I'll say. Seating and mobility, so specialty certification for professionals working in seating mobility. So it further validates the clinicians, suppliers, engineers that work specifically in seating and mobility service. So there's 179 SMS certificates today. Everybody is considered in the certification. It's not just for clinicians, it's not just for industry, it's just not for education. The intent is that everybody who works in the area of assistive technology has the proficiency to be able to show their knowledge with the ATP. So eligibility, there's three components. So there's a certain level of education, there's a certain level of work experience, and then you take the exam. I don't know if it's, yep, there it is. So we'll go through. So education is, showing, just looking at this, because if you have a degree versus if you don't have a degree, there's different breakdown of that. But then the education is what you've invested specifically for the training within assistive technology. So this lists some different criteria that are required to be able to be eligible to sit for the exam. The accreditation program. So wait, let me go back. So there's education required, and then there's work experience. There's certain hours. A lot of people have asked me, like, well, how do you validate, verify? There's a form, and so when I have my colleagues, I have to verify their work experience. It's my honor and ethics that I say, yes, this individual works this percentages, the percent of their time during their workday dedicated to this area of practice over this period of time gets you to that number of what's required for your work experience. And you just have to be signed off by a supervisor that you validate that level of work experience. And then once you have the criteria, then you apply to sit for the exam. Another thing that Resna has done is they launched an accreditation program for colleges and universities that provides graduates a benchmark of higher education and ability to achieve additional credentials for practice. So CORATE, Committee on Accreditation for Rehab Engineering and Assistive Technology. So currently there's three programs: University of Illinois at Chicago, University of Pittsburgh, and University of Washington. We have started one at OSU. It's a pretty rigorous process. So I'm very impressed by these organizations that have it, if you have the ability to access it. I definitely encourage you to do that. So hopefully you'll see OSU on there after we achieve that level. The forms for the question about where do we get the form for the work experience, it's on the Resna site. You can look right at the portal for the certification, and all the handouts are on there. Didn't they just apply the candidate program so you can sit for the exam without completing the work experience? You know what, Shea, I do not know, but I can find out. Heather, do you know?
I do not.
We'll find out for you, Shia. Okay, we'll keep going. Annual conference. So 2 days of pre-conference. We do teach this course at pre-conference. Then there's also other pre-conferences, 3 days of workshops and symposia. There's plenary sessions with keynote speakers, and there's student scientific and scientific paper poster platforms, student design competition, and a developer showcase.
Can you please call to Doreen? Please call.
Pardon me? Okay, I'm going to keep going. I go to a lot of different conferences, and my professional conferences definitely hit the first 3 bullets. The really great thing about Resna is the student scientific and scientific paper platform, the design competition, and developer showcase are, in my mind, just below this conference out as far as resources. So if you want more information about the conference, feel free to look it up. You can look at past proceedings to get a flavor of what is happening. Standards. So Resna has a standards board, and it is development of voluntary consensus standards in the U.S. that looks and views U.S. stakeholders and international standards forums. So there's a U.S. technical advisory group to the ANSI standards, which is American National Standards Institute. And then there's International Organization for Standards. So if you go to all of these things are on the website. So if you go to the Resna website and you want to look at standards, or you want to look at position papers, or you want to look at the conferences, there's all different really great breakouts. But Resna has 10 standards committees and 3 U.S. technical advisory groups. Very, very impressive. So take a look at that. We continue to work with international work groups to make sure that we're harmonizing U.S. and international standards. And during the conference, there's standards meetings that are in conjunction with the different Resna committee meetings. Other forms of leadership that Resna steers is position papers. I personally use all these position papers very regularly. Again, if you go to the website, here they are. Here's all the position papers, the application of pediatric power, seat elevating, tilt recline. You could read the list. But if you are working in the area of trying to get funding acquisition, I've referenced a lot of these position papers that in turn have a lot of research and literature reference. There's provision guides and white papers. So the difference between the provision guides and white papers and a position paper is the provision guides is a framework for looking at steps, and they provide guidance when funding should be addressed. One of my, let's see if it's up here. So here is a guideline on priorities for assistive technology and rehab research. So that's an example of a guideline. Another guideline is they actually just did I think it's called a white paper on the use of rehab engineers. So I just got a second rehab engineer approved at my facility, and I used this paper as a strong advocacy, and it showed the external evidence that was really powerful. And so if you are an engineer and trying to advocate for yourself, or you want to collaborate and bring someone onto your team, that's a great use of these. And then there's research guidelines. So guidelines that Resna membership research and other areas use kind of give us direction. There's a service and delivery guideline that I use for implementation of technology. Okay, the journal. I talked about the journal. This is a screenshot of it. And then there's forums. So if you have questions, exchanging ideas, one of my colleagues was asking about a certain mouth stick rest on a lap tray of a power chair. And we were like, I don't know, put it to the listserv. You can get a lot of really good answers and solutions pretty quick because it's all people that do what we do. The logo. So the logo has a meaning. It incorporates the ancient legend of the knot, which is a puzzle created to amuse Alexander the Great. So the knot in its solution is metaphor about how Resna members solve problems by thinking outside of the box. I learned that through this course. That's pretty cool. So the course has 10 modules that cover the range of AT services. So you're going to hear from me and Heather. And as we said, going over 2 hours. And we're going to go 2 to 3 learning objectives to let you know kind of where we're gearing the talk. And then at the end, we have review questions. And so the review questions are tied to the learning objectives. And, you know, try to answer those on your own. And then that helps us know if we taught the information in a way that synthesized well. I'm good at questions anytime. And we'll just, if we need to redirect it or maybe if it gets too deep, we may table it for later. And you have our email addresses. So if you have questions outside of these classes, feel free to shoot us an email. We talked about this, but you do get 1.4 CEUs. You have to pass the quiz. The quiz is 28 multiple choice questions. You have to answer at least 20 of them. If you don't pass the quiz, you have to wait 2 days and you can reattempt to take the quiz. And we want you to do the eval survey to give us feedback about the course, and that helps us make things even better. Within 2 weeks of passing the quiz, you will get your CEU transcript. We doing good out there? Okay, so we'll do another half hour, take a little break, and then finish up. So clinical applications, there's 2 parts to it. Goal is to recognize clinical diagnosis of individuals who use assistive technology, look at the characteristics, causes of these diagnoses, and recognize the types or categories of AT that may be used. So we know that everybody is very individual. We don't expect that generalizations of the solutions that we give are going to apply to everybody. So first part we're going to do is neurologic diagnosis. Hey, I'm going to pause for a second because I see hands going up. Heather, are you just answering those and you'll holler if you need me?
I am answering questions, yes.
Okay.
And anybody who has a hand up, do you need something?
Okay. This is where I kind of get into my zone. So you guys have to holler if you need me to stop talking. So we're going to go over neurologic disorders, and we're going to talk about the neural canal and brain lesions. In the neural canal, we're going to talk about spinal cord injuries and spina bifida. And in the brain lesions, we're going to talk about stroke, brain injury, and cerebral palsy. So for spinal cord injury, there's a partial or complete damage to the spinal cord injury. So you can see the bony structure is the vertebrae, and then that red is the your spinal cord. So right here, if this is a disc, if there's compression here, or if there's some type of trauma that disc is cutting into the spinal cord, that's where you're going to have the impairment. Depending on what the level is and where the impairment is going to be the resulting disability that has occurred. So this picture, here is a side view of the vertebral bodies. This is showing a crush or fractured vertebral body that is going into the spinal cord. And so it's showing an impact where there may be damage. So the word partial or complete, if the spinal cord is completely severed and no signals get below the level of injury, then you likely will have least chance of recovery. If it's in partial, so like right here, this is digging into it, but there looks like there's still signals that can get through. So then that shows you that there's a more likely chance of recovery. So I'm very visual, so I like those pictures. So a spinal cord injury is considered non-progressive. The word non-progressive is a little bit confusing because no disability is static, and it's usually the complications of the injury that end up seeing a person's change. So once you have a spinal cord injury, the damage was done, your body is trying to recover. It shouldn't have continual impairment, but you may have complications such as spasticity or secondary problems. A neurologic disease that continues to weaken the body is where you see something that's more progressive. Initially, after a spinal cord injury, there's some spinal shock, and then you have some recovery or function. So depending on when you see someone, and if you guys are working with anyone on the inpatient stay, people are being moved through the system pretty fast. And so we have to all do a really good job of using our evidence and understanding what the person's needs are. Because if they're incomplete and they're still in shock, we would expect them to have more recovery, but we're all expected to get the equipment before they leave the hospital. I refer to what the complete and incomplete is. If somebody has a traumatic spinal cord injury, such as a motor vehicle accident, a gunshot wound, a motorcycle accident, you may see different orthopedic complications, or you may see what we call the comorbidity for the head injury. Children that have a spinal cord injury, at a young age, are going to be at high risk for developing scoliosis because the spine is still growing, and then you have some areas of being unstable. I want to kind of do a check. Am I talking too fast for you guys? If I am, if somebody could holler and Heather will shout out to me. Okay, Michelle, thank you. So with the spinal cord, it's usually due to a trauma. In the U.S., auto accidents, sports injuries, and gunshot wounds are the most prominent types of injuries. We actually are seeing gunshot wounds surpass sports injuries, which the good thing is the sports injuries we're more aware and there's more prevention and more, action at the site. And unfortunately, we don't have to talk about why we're seeing more gunshot wounds, but we definitely are seeing a flip with that. Unfortunately, car accidents are still a big cause. We see a lot of young men, risk takers. Those are kind of the population that tends to be putting themselves out there more. A non-traumatic, so we talked about trauma, a non-traumatic can be a tumor or a stroke that occurs in the spinal cord. So with a tumor that is impinging upon the spinal cord, that may be where somebody has a non-traumatic. Depending on the type of the tumor, you can see more progression. If somebody has Mets to the spine, you may see more impingement. And with some of our older folks, what we see is falls that can also impact a spinal cord injury. So you have traumatic, non-traumatic, and then within those, you have different types. So when we use the word quadriplegia, and you will also hear the word tetraplegia, it means that all four extremities are involved. It means that there's paralysis and sensory loss. This kind of is my world that I've worked in I've been doing this about 26 years, and I've always worked with spinal cord injury, so I get really particular with some of my interpretation. Not all quads are incomplete, and so, oftentimes they can be incomplete, but what I want you to understand is the way the cord and the way the diagnosis is made is that these are all dermatome areas that you see. So when you have somebody that's in the purple, so this cervical level, so that means that their damage is at the cervical level, but then we test their sensory level. So you can have paralysis at C4, but you can have sensory all the way down to like T10 or even L2, or you can have sensory throughout. So somebody can feel their bowel program. They can feel when they have to empty their calf. They can feel when they need to do a pressure relief. So you can have sensory intact with motor not intact. And that gets into more specifically, they name it A, B, C, D because there's different levels. But when you're looking at assisted technology, somebody with quadriplegia is going to have pretty much impairment of their arms and legs. Someone with paraplegia is typically only going to have impairment in the legs, which means that they have the paralysis and or sensory loss in the lower extremities. So when you look at this picture here, a T2 would be a paraplegic because they would have everything above it intact. So meaning all these cervical areas haven't been damaged, but then this person with a T2 is not going to have any trunk. So when you're thinking of seating, they're going to probably need some solid back or some postural control. Someone with a T12 is going to have everything above that level intact, so they're probably going to have pretty good trunk control. A person with paraplegia can also have normal sensation or abnormal sensation. So when you're thinking of assisted technology, don't be afraid to ask more questions specifically on the unique needs of that individual. And you can say, do you have any sensation below your level of injury? Or do you have any movement below? The tricky part is the different syndromes. So I really like these pictures. So somebody can have a central cord syndrome. You usually see this with the cervical hypertension, and this is the picture here. So the red is where the compression is. So if you can think of I always have to think of an analogy. This is where my Italian gets in my way. So if you think of a garden hose and you squeeze it, the center of the hose is where the water has been restricted, but the outside of it is not damaged. So your damage is going to be where your nerves travel. So your nerves travel up through here, and your hand function is more towards the center to your leg function. So somebody with central cord syndrome usually has limited upper use, but they have sometimes normal walking. So for instance, they might be able to walk, but if they trip, they can't protect themselves because they don't have that upper extremity. I had a physician use this as like the barrel syndrome, where your arms are just kind of like in the barrel and you're walking. So with equipment, you're looking at a lot of things to kind of get their hand to their face with the self-feeding, with the computer, the phone. But with mobility, they may want to use a manual chair and just use their feet. Anterior cord syndrome is here, where the anterior cord is preserved, and you have the paralysis and the variable sensation towards the back. Around the cord is left and right. So sometimes it could look like a stroke, but because it's asymmetrical, so you end up having the impairment of motor function. But then if you look at the slide, the proprioception, so proprioception and motor are going to be on the same side, but pain, temperature, and sensation on the opposite side. It's because when the spinal cord runs up the track, it crosses over. And so once it crosses over, you have the opposite impairment. So you need to think about, again, sensory, your motor function, your equipment, your cushions, and stuff like that. So what we typically see with a spinal cord, we see paralysis, we see weakness, we see loss of sensation, and that's where we get scared with pressure sores. We can see different tone, so high tone, which is spasticity, really quick movements, or low tone, which is no movement at all. Typically, they're going to have some type of bowel or bladder dysfunction. So we want to make sure that if they need to manage their bladder while they're in their chair and they need that reclining, power recline, so they can empty their bladder, that's the justification that we would use there. Hypercalcemia is increased calcium. And so what that is individuals have their body will start producing more calcium. It tends to produce it at joints. If we don't continue to do range of motion, they can have limited range of motion at the joints, which turns into heterotropic ossification. So if you come up to somebody and they're not seated symmetrically or they're leaning to the side, you really want to look at what their range of motion is, because they may have HO and their leg may not be able to tolerate a certain position. And so we may need to accommodate that. And if we don't, then we're going to end up creating rotation and scoliosis and obliquities and complications down the road. Deep vein thrombosis is a risk of spinal cord injury. Early on, we just want to make sure that they are having the medication, they have TED hose. I don't really see that being an effect with the seating. Okay, I keep scanning to the questions. When we get to the lecture on mobility, I'm going to pull in the position papers on tilt and recline. If you want to go ahead and look ahead at them, we have to be able to, if I have an individual with a spinal cord injury that I want to get a power tilt and I want to get a power recline, I need to be able to justify why I want both of those. So a lot of people with spinal cord injury are able to empty their bladder on their own, and they're able to do that from their wheelchair, but they need to be able to recline back in order to access clothing management. So I tell the funding sources that that's why I want a power recline. And then I may want to tilt because I want them to do pressure relief because they're not able to do on their own. So when you're working with somebody and you're trying to think, okay, this person could really benefit from a recline and a tilt, how could we convince the insurance? Don't forget to ask them how they manage their bladder, because that can be your reason for helping them with the seat functions. That help? You guys are doing good with these questions. Pulmonary embolism, deep vein thrombosis. So because they're not moving, they can end up getting a clot in their legs. And if the clot moves up to their lungs, it becomes a pulmonary embolism. So we just want to make sure that the person is up out of bed. And I guess that's what the equipment is for, that we want them to be active and moving around so that they have lower complications for these two. Osteoporosis, people with spinal cord injuries become, their bones, they lose the brittleness of their bones as they get at risk for fractures. People with long-term spinal cord injuries, I unfortunately see people that end up breaking a femur during a transfer, or they end up getting broken bones to even when they're involved in like adventure sports. So we just need to be aware that their position is great. Okay. Autonomic dysreflexia. I'm going to take a breath here because this is something that a lot of people don't understand, and the community doesn't always understand it. So a complication of a spinal cord injury is dysreflexia, and essentially what it is the body's signal gets cut off. So if you look at this picture at T6 level, if you or I are sitting and, I'm going to say, like we have to go to the bathroom, our bladder gets full, we start to get uncomfortable, our body's giving us signs that I got to go to the bathroom, I need to take a break and go to the bathroom. When you have a spinal cord injury and the person can't empty on their own and their bladder is getting fuller and fuller and fuller, they don't have the same sensation that you or I do. So what happens is they get an autonomic response, and this is this here. I don't know if you can see my pointer. Your autonomic response is they would get maybe increase in blood pressure. Their face may get flushed. You may see splotches on their neck. You'll see different signs. And when I'm with a new person's injury, and I say, hey, you're looking splotchy, how do you feel? Early on, we have to help people understand what this feels like, because it's their body's way of explaining to you, I need to stop the stimulation that's creating this, but you need to figure out what that stimulation is. So the example I gave is their bladder is overly full. So they're going to become dysreflexic until they empty their bladder. Other things that are triggered is restricted clothing. If somebody has a pressure sore, if somebody doesn't realize they have a pressure sore and their body's just telling them there's something going on, anything that's creating a stimulation input, when you remove it, the dysreflexia goes away. If you don't remove it, then the body keeps doing the fight or flight and keeps telling the person that there's something wrong, there's something wrong. Well, what happens is that you're increasing your blood pressure and your heart rate, and so you could end up having, pretty bad complications if you don't address the dysreflexia. So in extreme cases, somebody can stroke out, they can pass out, they can become unconscious. But this is the important thing, is find out what is the trigger and remove the trigger. So we teach a lot of our injuries to read themselves. The experience I had in seating was I had a individual that was, I bet she was 30 years post. I knew her very, very well. She always sat on a ROHO, and she was starting to have problems with pressure sores. So we ruled everything out. We tried everything. And so I convinced her, I'm like, Carol, we need to do custom mold. So reluctantly, she's like, well, let me see what it feels like. So we had a, like you guys know with the ride design, how you have the simulating, I'm not saying it right, but it was a kind of pre-mold. We transferred her onto it, and as soon as she sat onto it, she started getting hyper. Her face started getting red. She started splotching, and I looked at her, I'm like, are you okay? And she's like, my face is red, isn't it? And I go, yeah. She just removed me from this cushion. We transferred her back onto her ROHO. Everything calmed down. So her body didn't like the sensation of sitting on that solid, hard surface because she had sat on that ROHO for so long. So had she not been aware, and had we not been aware, we could have created a pretty poor outcome, knowing that this cushion was causing dysreflexia. Okay, so the opposite of hyper is hypo. So postural hypotension, you usually see this when someone's getting ready to sit up. They've been laying flat, they've been in bed for a long time, so now they're starting to get up. It doesn't have to be just with a new injury. I've seen this with people that have been just bedridden because they have a sore, and they end up having to reacclimate their body. So what happens is once they sit up, their blood pressure drops. So they have a hard time maintaining a normal blood pressure and a normal blood flow. They get really lightheaded, they get dizzy. They tell me they see spots. And so what you need to do is you need to lay them down. You need to elevate their legs. And so if it's somebody that this is a long-term issue, then that would be the justification for power elevating leg rest and power recline, or power tilt. They need to immediately change their position. So spina bifida, how are we doing on time? I'm going to keep going. So spina bifida is when the end of the spinal cord doesn't fully form. So it's left with incomplete. So it's a formal definition is the deficit in the spinal canal due to incomplete formation during embryonic development. There's varying degrees of damage to spinal nerves and to the spinal cord. It's always the lowest part, so it's usually going to be like the T or L area. It's never going to be cervical. It's never going to be it's going to probably be lumbar. Sometimes it can be low thoracic, but it's never going to be like a high level like a spinal cord injury. It is, again, non-progressive. It's present at birth. It just depends on the type, how open that canal is. It says only survivable in lower spine paraplegia. So I would have to remind myself about the higher levels. I've only seen them in lower spinal paraplegia. And with the kids with spina bifida, they definitely have a high risk of scoliosis because this is at birth, so they're babies when they have it, and so we need to follow them and progress throughout to make sure their spine is getting supported so they don't develop scoliosis. You see a lot of rods placed with the kids and a lot of bracing. So meningeocele, myelomeningeocele are the two different types. So meningeocele is the opening of the spinal canal, and there's an incomplete vertebra formation, but there's no damage to the spinal cord. So if you look here, here's the pocket that it is. But if you can see, the spinal cord is intact. So this is the cauda equina. So this is, see how low that is? Myelomeningeal is where there's an opening, but there's a herniation of nerves or spinal cord into the opening. So that's where you see this right here. And that's where you're going to see damage to the nerves in the individual, maybe an incomplete ambulator or not a functional ambulator. And even if the kids ambulate at a young age, I usually see them as teenagers and adults, and they're usually in chairs for more efficiency. You do see hydrocephalus with the spina bifida, which is a buildup of the fluid in the brain. Sometimes you see skull distortion and some brain damage. You'll see shunts with the hydrocephalus. And Arnold-Chiari malformation is where you have part of the cerebellum protrude into the spinal canal. So here's a picture of the enlarged head, and then you can see the side view of the different ventricles. So some of these, we'll keep going. Some of the kids, so spina bifida with the first result. So paralysis, weakness, loss of sensation, low tone, poor trunk control. You're going to see some asymmetries, and you're going to see some poor motor planning. So this girl's standing, but if you can imagine if she was sitting, how we would need to get her a nice solid back. Other results, if you have visual impairments, because they have weak ocular motor control, where they have difficulty viewing things like fixating on objects and tracking and scanning, and they have poor perception. So if you're working with computer access in some different resources in the classroom, you need to be aware of someone with spina bifida that has some of the visual impairments that may not have been detected until they've been challenged in the classroom. The other part with spina bifida is cognitive impairments. And so you see a lot of people that are normal, but you can see up to pretty severe cognition, where you see the learning disabilities, language disabilities, attention deficits, and problems with memory. So those of you that are in school systems, my experience is this hits home a lot to some of the challenges that you have in the classroom. Applications for mobility, it really depends on the degree of the paralysis. You know, we see everything from ambulation aids to manual chairs to power chairs. Sometimes we see scooters early before they go into the powered chairs. Positioning, again, this is where it's hard to generalize, but you really want to make sure that you have that support because of the weakened trunk muscles, and you want to make sure that you have some good proximal stability. We want to make sure we're controlling the pressure on their bottom so that if they're not able to do adequate pressure management, pressure relief, that their cushion is protecting them. And they have a way of changing positions and being able to move in and out of movements. So looking at tilt, recline, standing positions, and 24-hour positioning needs. We could do a whole course on this slide right here.
Teresa, we have a quick question that about spina bifida.
Yeah.
About low tone. Does it always present with low tone, or is there also hypertonicity?
You know, this is my thinking phase. I typically see lower tone. I rarely see high tone with a spina bifida because of where the injury is. But if there's other complications with it, I wouldn't rule out that you would never see it. But my answer would be it is typically more low tone. Does anyone in the class want to add to that? you'll accept my answer? Okay.
And Stephanie, you have your hand raised. Did you have another question?
Looks
Okay.
like Stephanie, can spina bifida be detected during pregnancy?
Yeah, I already got that one. It can be.
Oh, you did? Okay. Okay. How am I on time? 8:28. Let's just finish this section on spina bifida and we'll take a break. So pressure injury prevention, this really applies to anything. So, if somebody can't move or they're having abnormal tone, we want to make sure that they can offload properly. When there's soft tissue wasting, if there's atrophy, there's just not a lot of tissue supporting those bony prominences. And so we want to offload. When they have no sensation, they don't know when they need to move. And heat and moisture can be an enemy in itself. Sometimes I can manage heat and moisture by clothing management and reducing the amount of layers between the person and the cushion. People worry about the incontinence. We don't want somebody sitting in a, wet urine because then that thins the skin. But we also want to make sure we're not putting too many layers between the person and the cushion. If you have Depends and you have clothing and then you have a sling and then the cover to the cushion, you just have a lot of layers. So maybe we want to, if the cushion cover gets soiled, you can sit on the cushion without the cover. And so you just want to make sure that until you can get the continence under control. Nutrition is a big deal. A lot of, work with spinal cord injuries my whole career. And again, those young, active thrill seekers aren't always good, don't have good eating habits. I think with a spina bifida, you're kind of teaching them to grow up with this. And so I think that some good habits are more likely to occur. And once you have a skin sore, you're likely going to be more at risk. So you need to be really aware of the skin integrity history. These, we're going to go into all these examples on the individual modules, but, if someone needs a vent support, if someone needs ADL equipment, and I'm just looking to see, I feel like this applies to spinal cord and spina bifida because I'm not going to see vent with spina bifida. But ADL, so any limited hand function is where the creativity of all of us comes into play. What do you need to do? So how are we going to figure out how to do it? Electronic ADLs is being really solved by apps and Alexa and a lot of resources that are mainstream. Alternate drive controls, anyone that has an access point, and we'll show you that in the wheelchair mobility section, we can help you drive. If you have that access point, the girl in the picture is also using the computer, so we can integrate multiple things into the chair, and that's the interface to technology. We're seeing a lot more architectural modifications. I think making sure that someone with a baby stroller can get in and out of a store and someone with a power chair can also. Transportation, helping people, whether it's public or private transportation, we're seeing some improvements with that. And then rec therapy is also one of my favorites, just lots of resources popping up out in regular parks and beaches to allow people with disabilities to interact in the community. So we'll pause right there. It is 8:32. 10 minutes. Good for everybody? So we'll resume at 8:42. Let me get back. Heather, you can hear me okay as my test?
Yep, sound good.
Okay, good. Okay, so we're going to keep moving through this. We have time for our quiz and questions, and I'm going to turn my head away from the chat after I answer that last question. Okay, so stroke. Stroke, the formal definition is, let me make sure that we're recording. Cerebral vascular accident, so CVA. It's a non-traumatic brain injury resulting in temporary or permanent occlusion of the cerebral blood vessels. There could be a rupture, which we hear as an aneurysm, and you also can have a stroke before, during, or after birth, which we also define as cerebral palsy. Again, a stroke is non-progressive unless they have subsequent strokes after. But I also just caution that even though the stroke itself isn't progressive, it's the complications and the comorbidities that will. Stroke has a very high survival rate, so 80% of people survive the initial stroke, and the recovery is going to depend on the individual and the degree of brain damage. It's also dependent on how quick that individual gets help, and so we see a lot of education on detecting if somebody may be having a stroke, because the quicker you can get in to the hospital, that increases your chance for speedier recovery. People with geriatric population, the older adults, they may have complications because they may have acquired other comorbidities or diagnoses. And some examples maybe, maybe they have COPD, maybe they have had falls and have fractures. We see a lot of arthritis. And so we have a lot of competing challenges. And then on top of it, they suffer a stroke. So we see a lot of the recovery, most significantly in the first 6 months. And then you will see it will continue. You see that, intensive dedication of people that just don't give up. We've learned the body, the brain is very placid. So with the neuroplasticity, we're seeing a lot of really great success stories. So the causes and etiology is ischemic stroke, hemorrhagic stroke. Ischemic is when there's a blockage of an artery and there's a thromboembolus. So that is the picture here. And then a hemorrhagic stroke is when there's a hemorrhage of an artery due to an aneurysm or arteriovenous malformation, which you'll see as AVM. You do see a lot of associations with hypertension, hypercholesteremia, diabetes, and so these conditions set people up to be a higher risk. So if you have hypertension, you are going to have more of a chance of having those complications that can lead into a stroke. So we talked about the ischemic, which is thrombotic and embolotic. We talked about the hemorrhagic, which is intercerebral and subarachnoid. And then we talk about brainstem that talks about the cranial nerves in the brainstem region. So the brainstem is like the base of your skull, and so you're going to have a more significant complication from this. I try to think, and I'm not going to try and get sidetracked too much because we have time here, but it's just so variable. It's really hard to put stroke in the categories like you do with spinal cord. I mean, I could really synchronize spinal cord injuries and have a better prediction than a stroke. So I'm looking back to see if they've given us better definitions. And so with a stroke, if you say, well, this person had ischemic stroke versus a hemorrhagic stroke, I'm not really sure that you can do your assisted technology any differently. You have to see how it's presenting and how the person is recovering. So the ischemic is when there's a blockage of the artery, and the hemorrhagic is when there's like that it's a hemorrhage, so it's bleeding into it.
Teresa, we have a couple
Heather?
questions.
Yeah, I was going to say it's hard to simplify this because it's a complicated process. So let's see. Subarachnoid. So subarachnoid is a location of where the hemorrhagic stroke is. It's a type of it's like a subclassification of the hemorrhagic. In short, a blood clot. Yep. I'm just reading.
Yeah, so right above that, it was about the thrombotic and the embolic.
So let me go back. Let me see how I have it. Ischemic, hemorrhagic. Okay, so ischemic is when there's a blockage of an artery. Let me pull this aside. I'm part of my screen. So there's a thrombosis or an embolus. So it depends on, so if somebody has the blockage, so coming through here, so ischemic stroke is because they have the buildup of, I'm going to really simplify. It's like when you say like the cholesterol and you have in your blood, you see the commercials with all the different like medications. So it can't get through. And so there's a thrombosis or an embolus that occurs in an ischemic stroke because it's something that's happening with inside a blood vessel. So yeah, it's like a blood clot. And then the hemorrhagic is it's bleeding outside of it. So ischemic, nothing's getting through. The hemorrhagic, it's bleeding outside. Other clinicians on the phone, is there a better way to describe that? William, yeah, arachnoid covers the brain below the dura. You guys are really deep. Let me think about how to better explain that, and maybe I can bring back a couple slides next week. Is that fair? And for the cause of the exam, it will not go into this much deep. You just need to understand there's different types of strokes. That's how you know, stepping back on trying to not get too deep into a rabbit hole for the level of complexity. The exam is not going to test you on defining the differences between these. So if someone, a different type of stroke, and sometimes I see this with like a brain stem where somebody is locked in. So locked in means that they know what's going on. They are aware of everything around them, but their system has become so impaired that they have no ability to communicate. So if somebody has a stroke in the pontine area, which is an area of the brain, they can result in a locked-in syndrome. Sometimes the only thing they can do is blink their eyes. And if you think about assistive technology, that's where eye gaze comes into play and different communication boards come into play. So for the exam, it may present that this individual has locked-in syndrome as a result of the stroke. As a team, you're trying to look at the best piece of assistive technology to help them communicate. So you would know that that phrase locked in means that they don't have much ability and that an eye gaze would be a positive result. So I hope that gives a little perspective to not get too worried about the different ischemic and hemorrhagic strokes. So one type of result from a stroke would be paralysis, weakness. Usually it's going to be asymmetrical, so one side of the body. They're not going to have efficient motor control, so movement. They're going to have impaired balance and coordination. They may have impaired sensation, and they may have low or high tone. If they have high tone, they may have joint contractures. If they have low tone, they may have subluxation. What the subluxation is that the muscle that holds the arm up into the, I'll say shoulder cavity, because that is weak, the weight of the arm gets pulled down, and then you end up having a subluxation. So a type of assistive technology would be a lap tray, or that's why we call them upper extremity support. looking at, someone has decreased motor control and decreased balance, so we may need to look at what the postural and positioning devices are for that individual. Another type of stroke can be difficulty planning and executing movement. Maybe the person has difficulty with bowel and bladder control. Maybe they have impaired language processing. Maybe swallowing is difficult. And maybe you see some behavior issues or neglect. So all of these happen to be the areas that are responsible for the functioning of these certain systems. So if somebody has neglect, meaning that they don't even pay attention to the left side of their body, and maybe they're very impulsive, so they have behavior issues, that might not be somebody that would be safe to be in a power chair. If you don't know a lot of the medical history and you're working with somebody in a power chair and you're seeing that they're not successful, maybe you can say, can you tell me a little bit about the medical condition? Where was their stroke? Do they have any impairment in maybe seeing, like when they're eating their meal, they can see their whole side of the plate? And so trying to understand the cause of the behavior that somebody is not safe in a power chair because they have neglect as a result of the stroke. On the flip side, giving people a chance and not making assumptions that if you are able to compensate for the impairments, then you may be able to use a certain equipment. Always trying to go back to the root cause and asking questions, and having, if you're a vendor, asking the clinician. If you're a clinician, asking your medical team. Another type of stroke have mainly cognitive deficits. So you might see less physical and more cognitive. And so you might see some of these people with needing or wanting to use the computer access or memory aids and different types of devices that they want to compensate for because they're impairment from the stroke. And we need to look at what types of technology they would have the capacity to use. Another type of stroke is someone with visual deficits. So impaired visual field. So if someone has I can never say this word, hemiopsia, so they can only see the left side of their environment, which means that they really, really have to rotate over to compensate for it. Somebody that has double vision's easy to explain, just see double of everything. And then this is a visual field cut where they can only see part of the vision. Sometimes people see poor acuity. So acuity is what glasses help us with. So with what my optometrist says, I have more birthdays than some other people. So I need to use reading glasses because my acuity is impaired. But my perception is something different. Perception is how we interpret things that we see. The perception is how close is that doorway from where I'm at? Where is that step compared to where this area of the room stops? When we're driving, we use depth perception all the time. So the perception is how we interpret the environment. Acuity is how we see the environment. If you have impairments in your vision, you may only be able to see part of your environment. One of my soapboxes is with powered mobility, you need to get people into the chairs and do some functional trials. We'll talk about that more when we get into that area, because people can compensate, and even though their brain hasn't been corrected, they can learn how to work with it by scanning and having different strategies. This is a nice slide because it goes over typically what you see with what the right brain is responsible for and what the left brain is responsible. So if you see has left hemiplegia, their stroke has been on the right side. So if you have a right CVA, they're going to have left hemiplegia. Hemiplegia is weakness. You typically, when have a right CVA with the left hemiplegia, you're typically going to see vision loss, perceptual problems, neglect, impulsivity. You're going to see those behavior. With a left stroke, left CVA, you're going to have right hemiplegia or right motor impairment, and you're going to typically have language impairments, poor motor planning, poor math, and slow. But typically you're not going to see visual issues, and that has to do where all those areas are stored in the brain. And because a left CVA, the left side isn't where the visual, perceptual, impulsivity sit, that shouldn't be affected.
All right, Teresa, we have a couple questions.
Okay, who is best to determine power wheelchair competency? Is that what it is, power wheelchair competency? This is a big question because the medical team needs to be able to say that the person is safe and independent. How do you accomplish that, in my opinion, is through a trial. There are some power wheelchair tests, not a lot. It's an area of the literature that probably needs expanded. But if you look at wheelchair skills and having somebody perform in the equipment, that's going to give you the answer. Does that help you? Is it Marisa? Hemianopsia is just the left side, or it could be either. It could be only the right or only the left. For Bill? Oh, good.
And there's one other about, I think it's just the slides, which says what determines result 4 versus 1.
I think those are just examples.
Yep.
My understanding is we're just trying to say, hey, case study 4, like case study 4, case study 3, case study 2. Is that what you mean? So they're kind of looking like this would be, as case study 4 is probably somebody that is a right CVA with left hemiplegia. So we're just trying to give you case studies. That helps? PTMD, okay, who helps, who does it? My experience in my clinic is that the clinicians, so the physician and the clinician should be working as a team, but the clinicians are the ones that are going to do the trial. I have 7 therapists that are in my seating clinic, and so I know that's a little unusual. All we do is wheelchair evals. So I have the OTs and PTs pretty much cross-trained. Different clinics have different therapists that lead the show with seating. And so I feel like either a physical therapist or an occupational therapist can make that determination. If you're in a school system, I use the teachers a lot. We collaborate with therapists in the school systems, and so we pull in the different assistive technology specialists, and we look at the whole team to look at somebody is ready for power. And then we report back to the physician who has to ultimately make the final decision. That answer your question? Okay. PTOT can make the referral. Oops. Okay, good. So I keep going then? Okay, so here is the applications on mobility. So it definitely depends on the weakness. Some people can use ambulation aids such as walkers, canes, crutches. Some people can use wheelchairs, and some people can use power. We're going to have whole modules on these for mobility. So positioning, you know, someone with a stroke is going to have that asymmetry because only half of their body has been affected. So we need to make sure that we're giving them the proper postural support, and we're supporting the arm and helping it stay elevated and making sure we don't get any edema. Looking at all aspects of assistive technology, what do they need to help them be most independent with taking care of themselves, with self-care, with showers, with toileting, with kitchen, with home management, with meal prep. I'm really looking at top to bottom of what we can do to help them. Not forgetting the cognitive aids, reminders, alerts. My cognitive aid is my phone that I have everything stored in. And so I've really appreciated where these devices have helped us. I just scanned over, is there a certain age where a power wheelchair is acceptable, or does it depend on the child? Take a look at that position paper on pediatric power. You're going to love it. There is not an age. It's when the child can show cause and effect. And we've done a lot of really good research in this area. And take a look at that before we get into the power. So it's the position paper on pediatric power. Computer access with one-handed keyboards, recreation aids, making sure that people get out and about and socialize, and then helping them with architectural modifications so they can access the world. So brain injury, stroke and brain injury is sometimes similar, but with a brain injury, we usually look at a sudden trauma or an insult to the brain. So just to kind of pause for a second, wherever the stroke is going to occur is where you're going to see the impairment. So we're not doing a deep dive into neurology, but if you haven't seen this type of schematic, like if someone has a frontal lobe stroke versus an occipital stroke, wherever the areas that are kind of mapped out is where you're going to see the impairment. So when someone has a brain injury, if they fell and they hit the parietal lobe, or if, again, the temporal lobe or a gunshot wound, that's where you're going to see the impairments present. Again, like the others, it's not progressive. Usually you're going to have that insult and it's not going to spread throughout the body, but you're going to have the complications from the injury. The recovery is going to be based on the individual and their premorbid condition and their health, and as quick as they can get the recovery. And initially, they'll look at the severity level classified on the person's response in the trauma. So like, how they respond to eye-opening and closing, motor responses, verbal responses. Very large population, 1.4 million people a year. We do see with this diagnosis higher in males and higher in late teens, early 20s. Think about that risk taker population. Similar to spinal cord injuries, you see a lot of motor vehicle accidents, sports, recreation, violence. We're seeing a lot of concussion rolling into this group. So a traumatic event can be those three bullets, but you can also an anoxia or hypoxia. So if someone had a heart attack and was anoxic, so maybe there was a period of time where they weren't, their heart wasn't beating. If they become toxic or there's a metabolic condition, sometimes we're seeing this with some of the drug overdoses. And if there's an infection that can lead into complications, we can also see that with a brain injury. When we talk about traumatic injuries, we're talking about a closed head injury, an open head injury, and a penetrating. So a closed head injury is when there's an impact between the head and a blunt object. And I think of that is if somebody is in a car accident and their head goes forward and then goes back, so their brain is moving within the skull, but there isn't an open trauma. So you have the head that is hitting like the windshield, and then it hits the back, or even hitting the airbag and hitting the back. And so you have that forward and back momentum. Open head injury is similar, but there's a skull fracture. So the dura has become open. And then a penetrating injury is when a foreign object penetrates the brain. So obviously a gunshot wound is the easiest penetrating injury that you would think of. The non-traumatic is what you think. It's not something that is causing it. It's more of like anoxia. I use the example of a heart attack, but near drowning. So if somebody drowns, you go to retrieve them, they come up, they weren't breathing, you perform CPR, they may be anoxic because they had a period of time when they weren't breathing. And then the toxicity is like a meningitis or encephalitis. Whoa. So if there's initial loss of consciousness, and someone's in a coma, there's different lengths of time that they're in coma, and they may have loss of function in many, many areas, and they may have had seizures. Another example is if you have somebody that they have a recovery within the first 2 years. The stroke, it was 6 months. And so with brain injury, they look at the first 2 years, and they do believe that, you do see people continue to improve, but what happens is that if there's an area that's partially damaged, then you end up finding what I call rerouting, and they start learning new patterns for that remediation. If it's an area that was controlling a very specific function and it's completely destroyed, the function is permanently lost. With some of the brain, and it's interesting, they don't have brain tumors as a non-traumatic. I'm always thinking of adding, but a brain tumor can also be what I would consider non-traumatic. So if you have a brain tumor, you have to remove a certain area. You haven't had a chance for those neurons to get rerouted. So another result, you see paralysis and weakness, sensory loss, abnormal tone, poor motor control. When you think of this, if you think of lining 3 people up, somebody could look like a brain injury or a stroke, and have very similar presentations, and that's where our learning with assistive technology helps us decide, oh, well, this person had poor trunk control, but it's because they had a stroke. This person has poor trunk control, they have a brain injury, but the application may be the same. So trying to go back to the root cause. Someone with a brain injury can have balance impairments. They can also have vision and hearing and speech problems, and they can also have emotional behavioral. The difference between the brain injury and the stroke is that with that slide with the stroke where you see left CVA versus right CVA, that's pretty accurate. With the brain injury, it's usually more like diffuse, and it can look very different from person to person. You can also have someone with a brain injury that doesn't have any motor impairments, but they have all cognitive, memory, attention, and perception. So this person might not need the seating and wheel mobility clinic, but they may need the computer access. They may need help with some of the communication, and they may need some of this memory age smart clinic technology. The AT applications for mobility, as I said, it's going to depend on the degree. Some people may need just ambulation aids, others may need manual. And once you go into power wheelchair, you need to be very aware of safety assessments, because just like with someone with a stroke, someone with a brain injury may have some underlying cognitive or visual reason why they're not being safe. Positioning, this is a picture of a dependent chair. And so some people that are not independent with their own mobility but need the assistance of a caregiver, we may be doing wheelchairs for positioning and comfort, and looking at helping when that person's up out of bed, keeping them safe and injury-free, and having less complications for deformity by using a manual tilt and space chair and helping them with positioning. As I mentioned, there's a lot of people with a brain injury that don't have any physical motor, that have cognitive visuals. So looking at cognitive aids, reminders, alerts, looking at some self-care needs. I also think of medication management, looking at computer with alternate access. Again, my EADLs is looking at just what is that smart technology available that can help people, whether it's reminders or, hey, Alexa, set an alarm for 2 o'clock for me to take my medication. Sensory and vision aids, and then communication. So cerebral palsy, another form of neurologic. It is a non-progressive disorder that results in resulting from a lesion to the brain, and it can be any time from fetal development during birth to 2 years of age. Typically, it is non-progressive. Again, are you seeing the pattern with the words? Whoops. But I just always like to say that it is the complications from it. So it looks like the studies that have been conducted, the timing of injury to the brain, 70% of the impairments have occurred before birth, 20% during, and 10% after. So 90% have impairments to the brain, right as that child is coming into the world. So there can be minimal to severe involvement. There's a very wide spread of how these individuals present, and seizure disorders can be on top of it. The cause is that there's damage to the nervous system during formation of the fetus. There's maternal dysfunction, a premature separation of the placenta, bleeding in the baby's brain. There could be anoxia in utero or during birth, and there could be injury to the brain during swelling. And the postnatal causes include meningitis. There are different types of cerebral palsy, and they're classified predominantly by muscle tone and movement. So these words of spastic or hyper cerebral palsy is where the definition for spasticity is velocity dependent muscle tone. So quick, fast movements is spasticity. Hypotonic is, as we talked about earlier, low, no movement. There's dyskinetic, which is a movement disorder, and so athetoid and ataxic. I'm throwing a lot of words at you. So somebody can be a spastic cerebral, these are words you're going to hear, spastic cerebral palsy, hypocerebral palsy, or athetoid cerebral palsy. The thing that you need to remember with the athetoid and the ataxic cerebral palsy is that their ability to interact and interface with the environment. So somebody with spastic quadriplegia, so think of spinal cord injury. Quadriplegia is 4 limbs, paraplegia is 2 limbs. Cerebral palsy can occur anywhere along that spectrum. So breaking it down, if somebody has spastic cerebral palsy, they can also have dyskinetic movements. And so thinking about, can they push a manual chair? Should they push a manual chair? What type of alternate drive controls are needed? You see a lot of different movement patterns with someone that's athetoid and ataxic, and these individuals are going to need the entire team. A lot of these kids are very aware and they don't have cognitive deficits, and those are the ones that need all of us to come together. Somebody that has cognitive impairments that isn't able to interact may be more dependent, and so being able to differentiate this slide, I think, is important to be comfortable knowing the differentiation of. So kind of go through. So this is a picture that just goes through and shows you the different types of cerebral palsy, and it just, again, explains it a little more detail than what I just explained. So the ataxic, very poor balance, stumbling falls, and athetoid is constant uncontrolled movement. So this person may be like more squirmy. This person may be more like robotic in movement. It doesn't have fluid movement. Spastic is just fast movements. Rigidity means that it's very, very, very tight, slow. It's hard to move it through space. And then tremors can occur with any of them. So I kind of jumped ahead when I said quadriplegic, paraplegic. This kind of goes through. So depending on what body is involved, I use the word spastic quadriplegia. So you can have cerebral palsy that's para, you can have cerebral palsy that's quad. And then if you think of the stroke and where you have monoplegic, which is 1, and diplegic, which is just the lower, and then hemi, which is one side of the body. So it's essentially presenting on how they have the functional ability. And then these are the pictures that are associated with this. I think this is a really good slide to help you look at that. I have worked with every one of these tones, and your quadra spastic quadriplegia, super involved. And then I have a girl that's diplegia that she rides a recumbent bike with just some extra positioning. So the spectrum of cerebral palsy is pretty wide. So getting into the cases, somebody can have muscle weakness paralysis, they can have abnormal tone, they can have movement disorders, they can have poor sensation or lack of awareness of their sensation, but they may have primitive reflexes and they may have oromotor problems. The picture here is ATNR, which is asymmetric tonic neck reflex. And so if the kiddo is looking to the right, they tend to extend their right arm and flex their left arm. So if you have somebody, and it doesn't have to be just a baby, but it can be through, adolescent adulthood. So if you have a teenager and you're looking at driving power wheelchairs, they have an ATNR, a strong reflex. So all of a sudden they look to the right and their right hand extends. Guess what's going to happen? The joystick's going to go to the way that they're looking. So you want to try and be aware of these. In the clinical world, we disinhibit those reflexes. So not that we're preventing them from looking to the right, but looking at if they have like a high guard and different facilitations, we want to get good proximal stability so that we don't kick in some of those reflexes. Someone can have visual problems, so the ocular motor problems. People can have asymmetry in growth and development. It can lead to GI problems, bowel and bladder problems, perceptual deficits, or cognitive deficits. Application, similar to what we've seen so far, depending on how they present. We can do ambulation aids, which include crutches, gait trainers, walkers. We can do strollers, manual chairs, or power chairs. Some of the kids may have ambulation aids as well as a manual chair. Some might have a stroller and a power chair. So a lot of times we'll see multiple pieces of technology with cerebral palsy. We want to make sure that we're really supporting and maximize the function with positioning, and we want to reduce any of that muscle tone and minimize any of those reflexes, making sure they can tolerate our seating and helping with allowing that child to grow and preventing any complications such as the scoliosis. Continuing with our whole spectrum of assistive technology, we want to make sure that they can interact in the classroom, make sure that they can interact at home, making sure that they have access to the same tools that we do, whether it's a access for using a computer or if we're pairing the power wheelchair with a communication device. We want to make sure that we offer those opportunities and have adaptations with toys and be really mindful of what's available in the classrooms. They have the same opportunity to learn as able-bodied kids. We're doing it. So we have 10 minutes for questions. And I think what's helpful is if we can go into the test, and then that might generate some questions. Does that sound good? Or does anyone have any questions before we roll into the test? Okay. Okay, Heather, let's see if I can do this. I'm going to launch the test. Can you guys see it? This is where I can't see the test. Can you see it? Do I have you guys there? No. Emily, you can't see it. My face is full screen. That's really scary. I'm so sorry.
Yeah, it looked like it launched and then it disappeared. So
part 1. I think when I tested, I closed it. I'm sorry. Okay, so what can you see now? Can you see anything?
The question slide's up right now.
There is a question. Can you read the question?
It just has the questions slide. So no actual questions to take the test.
So what happened?
Some people are seeing it.
Oh, I see.
Some people aren't.
So I launched it, and when people said they couldn't see it, your face in the upper fourth and question slide in the lower. It's saying that it's closed. That's why I'm confused. Screen sharing. Just the question slide. That's what I'm seeing too. So if I do the test, it's now only giving me a chance to review it.
Mm-hmm.
So let's just let's review it. If you guys want to tell me if you can see it, the whole test results. Can everybody see the test submitted, the questions?
Yeah, that's showing now.
Okay. So the first question was, aphasia is common when the stroke occurs in which side of the brain? So the correct answer, as you can see, can you see the correct answer on there? It's the left side. I think it closed too quick, so I apologize. Nobody will be negatively affected, but if you want to take a picture of this, these are the questions that you may see again in the big exam. And so this is kind of prepping us for the big exam. But aphasia is common when the stroke occurs on which side of the brain? Left is the correct answer. If you go back to that slide that had the left side versus right side, that's where this answer comes from. So I can't test if I taught it correctly because I closed it before you guys got a chance to answer. And I will do better tomorrow night. I hope you guys all come back. Number two, a client has experienced a stroke that affected his left side. Why might a molded cushion be on the left armrest of his chair? So the correct answer is to support his left arm. The reason the others are not right, so to encourage him to lean towards the left side, we don't want him to lean that way. To protect the surface of the wheelchair, we're only talking about the arm. And to reduce proprioception of the left arm, we don't want to reduce proprioception. We want to give him more awareness of his left side. And then number three, spinal cord injury and spina bifida both fall under which neurologic disorders category? They both have the neurocanal being affected, because if you think of the spinal cord injury runs through the, remember we had the bony prominences, and then the spina bifida is where the spine doesn't properly close, so there's opening in the neural canal. So the spinal cord injury and spina bifida both fall under the neural canal. They are not hereditary, so you can't acquire a spinal cord injury or spina bifida because of genetics, and they're not degenerative because they're non-progressive. They're not a brain lesion, so they don't get caused as a result of an impact on the brain. It's purely an impact in the spinal cord neurocanal, and it is not genetic, and it's not degenerative. It's non-progressive. Okay, so we had a lot of information tonight. Tomorrow we'll be able to, or Thursday, we'll be able to jump right into clinical applications 2, and we won't have all that the Resna stuff. And I see a hand, maybe?
Yep, looks like Beth.
Okay, the hand was left over from what you could see. Okay, so my homework is to work on my headset and to review the polls so I don't close it too quick. And then Heather and I will see you Thursday at 7:30 for clinical applications 2. Heather, any closing remarks?
Nope, that's it. Stephanie did have a question about what chapter of the book reflects what we learned tonight. That
I don't have the book in front of
yeah,
you, but it's, yeah. So this week and Thursday is all clinical applications, and then we're going to get into specific technology. We'll kind of reverse through and give you examples with the technology of some of the applications, but this is intended to kind of give us all baseline of the human body. Stephanie, is that a sufficient answer, or would you like me to check with Charlie? Okay. Well, I'll stay on for a few minutes until everybody, information chapter 1. Thanks, Roel.
And then Therese was asking about how they take the quiz for tonight. The quiz is just to kind of do a quick review at the end of class, so it doesn't affect any scores or anything with the class.
Right. So you will have a better chance on Thursday because I won't shut it down quick.
We could even rerun it on Thursday. So, yep.
Yeah, that's a good point. Yes, do that. Okay, I'll stay on. Thanks, everybody. Heather, I think we're good.
Okay.
Thank you very much.
You're welcome.
Talk to you Thursday.
Thursday it is.
Okay, bye.
Bye.